We'll wait just a couple seconds to let everyone join and then we'll begin. Okay, welcome to the Healthcare Lounge. Our topic today is repricing healthcare with direct contracts, and we have a couple special guests with us, two Dougs, Doug Hetherington and Doug Geinzer. And now I will turn it over to Nelson.
Thanks, Kendall. Welcome to the Healthcare Lounge. We have a terrific program today. We have two absolute rock stars, renowned experts in the topic of direct contracting who are working with brokers and advisors around the country to make direct contracting a part of the health plans that they are building for their employer clients. Let me provide a little bit of historical background and sort of texture. Let me lay the concrete here for what you're going to hear from the Dougs, as we like to call them. The problem in healthcare is the insurance companies. That's the problem, and the biggest problem with the insurance companies in a lot of ways are the networks that they provide. First of all, they are the only valuable asset the insurance companies tend to have anymore. People really just want the networks. But the challenge that you all as advisors face is the networks are horrible. They're a great deal for the doctors, I guess, and for the hospitals, not such a great deal for, and a great deal for the insurance companies. Not such a great deal for employees who are seeking access to healthcare, and certainly not for the payer. And the payer is always the employer. It's never the insurance company. The insurance company is a bank, and they are spending other people's money. There is a solution that a lot of advisors are using to address this problem with the PPO networks, which are a repricing mechanism. The problem is they're repricing with a discount off an arbitrarily and unreasonably high retail rate that nobody pays. So the first solution, or first a way to address that, was reference-based pricing. Because reference-based pricing works with a markup on top of a cost number, which has been primarily Medicare rates, Medicare reimbursement rates. The problem with and RBP works, and RBP is a fantastic tool, but RBP, frankly, is a bandage on a cancer. And the cancer are the bad network contracts that the insurance companies are presenting to employers in their either their fully insured health plans or their or for self-insured plans that want a network. The longer term solution, the real solution to the network, the carrier network problem, is a better contract, a new and better contract that aligns incentives and is a win-win for everyone involved. Now, people tend to think of direct contracts in our industry as hospital direct contracts, contracts between an employer and a health plan or a hospital, and our health system and a hospital. And that is certainly a viable option. But there are also point solutions, single point solutions, such as a contract between a surgeon and the employer, which generally shows up in the form of a cash price bundled surgery package. So we've got experts on both of these approaches who not just, I don't want them just to talk about the direct contracts, but rather some of the process around it, how to leverage these solutions within a health plan, and how they are working with those of you on in this meeting who are already working with them, and how they can work with those of you who are not yet working with them. So let's start with hospital direct contracts. And historically, these have been done as a one-off set up by an advisor. In fact, Beth Johnson and Deke Lape in our Next Gen Benefits Mastermind partnership are early pioneers in this. They set up a direct contract with a local hospital in their market, and they've since expanded it to 3 or 4 other markets where they have direct contracts. But they will tell you that it was painful. They made more mistakes. They made costly mistakes, and potentially extremely costly mistakes. Fortunately, didn't work out that way. But today, it's a much easier process for you. You don't have to go build that direct contract and negotiate with the hospitals, et cetera. So let me ask Doug Hetherington of H2B, talk about the landscape now with hospital direct contracts and contracts with other healthcare providers on a sort of a more permanent basis.
Yeah, it's changed a lot over the last several years. We've seen kind of this evolution take place. And, I think part of it is being driven from, the health reform discussions. What we hear from hospitals regularly is that the relationship between them and the traditional payers, right, those traditional BUCA networks, is deteriorating and at a rapid pace. And so you can kind of correlate the experience of the employer and advisor getting these large increases every year, feeling like they're getting less and less value. And yet the hospitals feel pretty much the same way in the whole equation. So you can imagine why they would have motivation to then say, well, let's bypass those traditional insurance companies and go work directly with the employers, right, who we believe are the true payers. The challenge that comes along with it is, I guess the beauty of a network is that it is infrastructure, right? So it kind of creates a digital process by which you can submit and have claims paid. And that's really the challenge with reference-based pricing, is that you've basically eviscerated that digital efficiency, and it's a dictation from the plan telling the hospital, hey, here's what we're going to pay. So they don't like that approach either. And so this direct contract really in the middle of those two becomes kind of the preferred solution. And I think what it brings for really, we view stakeholders as being employers, the providers themselves, and the patients, right? Typically the 3 people that are disadvantaged in the traditional network structure. And what we're really trying to do is find, gains for each of those stakeholders. Obviously, more stability from a pricing standpoint, predictability with the employers. On the hospital side, we always think about it. They're not really PPOs. There's nothing preferred when everybody participates. So they would agree these are, all payer organizations. Or all provider organizations. And what we're actually doing is kind of bringing back some semblance of preference for that health system, that hospital, as you stated, so that when members need care on a fairly efficient basis, right, hopefully there's a basic directory in place, they're now able to go seek those benefits from those preferred contracted providers. And usually now we're not subscribing to a go here or else mentality, but rather a go here and here's what's in it for you. So much more of an incentive-based type approach, very similar to what Doug and their organization does. I think I call it tier 0, which I just think it's an awesome way. Give the member the ultimate motivation to go make the right decision at the end of the day. And then finally, for the health system, right? What's in it for them? Well, we hear, if you've read anything this year about prior authorizations, seems to be just a rampant problem going on out there, where all of a sudden the payers just don't want to pay, or they're taking 3, 4, 6 months to submit payment on what are fairly routine care episodes. And so that has caused a lot of consternation and frustration. Well, we can eliminate that in a direct contract. So those are some of the benefits that come along with it. Similarly, when I got into this, right, I was a frontline advisor. Went up and set up a couple of direct contracts with, a couple of smaller health systems in a rural community, had to start kind of building out from there. And every time I started to feel like, okay, I'm starting to get a grasp of this, something would happen. And I'd realize, oh my gosh, I don't know what I don't know. And so that was really why we started Health to Business. It was this recognition that there are great efficiencies that can be gained through direct contracting. But if you don't know what you're doing, you're going to create a tremendous amount of issues. You're going to put in a lot of work, and ultimately you may break some what are very key relationships for you as a professional trying to do the right thing, but because you just lack experience or even resources, unfortunately, it results in an inferior experience. And so everybody kind of goes back. So our goal is to create replicability and scalability around direct contracting so that it can be successful in perpetuity.
Nelson, you're on.
Somebody slipped me $10 to put myself on mute, and I forgot to take myself off. Doug Geinzer, thank you, Doug. And Doug Geinzer with Coral, you're working with and have a lot of experience working with surgeons and surgery centers to put together these bundled price, bundled surgery packages. Talk a little bit about that, how that differs from, let's say, a hospital direct contract, and how did you come into that? Just as Doug explained how he ended up working with hospital direct contracts, how did you get into the physician bundled price contracting business?
Sure. So let's kind of start. So I got into it just physicians are the true asset in the entire equation. I look at hospitals, ASCs, and all the facilities as nothing but a commodity. I know they don't like hearing that, but they're four walls and gas. It's really what they are. The asset in the entire equation is the surgeon, and what the surgery centers allow that surgeon to do is to bring autonomy into the surgery, into the operating room. So if you think of the quarterback of a football team, imagine that quarterback going out on the field every day and not knowing what their front line looked like. That's what a surgeon feels like when they go into an OR of a hospital, because it's the hospital aligned vendor stack. So it's the anesthesiologist from the hospital, the scrub tech, the OR tech, the OR nurse. And many times this team has never worked together before. So one may be a per diem, another one may be a rotating person, another one may be a new grad. And so the autonomy just from the instrument handling goes south. And unfortunately, the surgeon gets held responsible for their outcomes from a team that they can't control. So in the ambulatory surgery center setting, many times or most times, it's the surgeon's team that's in the OR. So they're able to operate more efficiently. They're able to bring higher quality standards because obviously the surgery centers are just a cleaner environment. It's where healthy people go, sick people go to hospitals. So if you look at the national standards, I think hospitals are at about a 9+ above infection rate. Most surgery centers that we work with are sub 1. Quite a growing group that haven't had an infection in their ASC for a couple of years now. So that's kind of the why and why we like that. Now, if you look at it from a cost perspective, which is why we're all on the phone today, if you look at a surgery, about 80% of the cost of that surgery lives in the facility fee. And so for those that don't know what a bundle looks like or an episode of care looks like, there's typically 4 components to it. You've got the facility, the surgeon, the anesthesia, and the implant. And it's the facility fee that drives the overall cost of the procedure. So when you think about it, 70% of cases don't need to be done in a hospital, but are being done in a hospital. And you move that over to an ambulatory surgery center, you're getting 2 big things. You're getting cost containment, because you're able to lower the cost of that 40 to 60%. And a natural byproduct of that is you're getting a quality improvement because you've got a surgeon that's able to work with a little bit more autonomy within the operating room.
Thanks, Doug. There's a cost is probably the foremost consideration in healthcare, and certainly in healthcare plans run by employers. But there's also the issue of quality. And so, Doug Hetherington, how does quality factor in to your deliberations, your selections of hospitals and health systems to work with, and how does that continue to be a consideration?
Yeah. Well, I think that the reality is there's always going to be subjectivity in quality from a healthcare standpoint. I think Doug's example was fantastic, right? I mean, you've got a group of people that are all probably, highly educated, highly motivated to do the right thing. And yet just from a lack of experience of working with one another, right, you could have potentially, bad outcomes. And I think that that's something that we have to recognize exists within healthcare somewhat purposefully, right? As you said, the insurance companies are really the reason that we're in this whole debacle. And it's because they've maintained all the control up to this point. They get to determine what's quality, what's not. And I think as an industry, this is an area of significant evolution that we're going to go through. That is, now we have pricing transparency. We're going to be able to better correlate the value of price against what are the outcomes of this on a provider by provider basis. So I believe the future, we're going to get a lot better at this. In a direct contracting model, I think you have to approach it a little bit differently than you would in maybe more the traditional network, where you have credentialing, you have network adequacy that are all these requirements. A lot of that kind of goes away. And maybe one of the benefits of a direct contract is the simplicity of it, where to some degree we can take the quality component and set it to the side. Because what we've replaced that with now is a relationship. And what I tell my clients often, and when I'm sitting in front of a hospital CEO or managed care, and they're even asking, well, what should be in our contract that deals with some of these quality metrics, we say the CEO of the business down the street is what's going to hold you accountable, right? So if you do not take good care of their people, then ultimately they're going to come and have a conversation with you. A great example of this was several years ago in one of our early programs that we had set up. We had been contacted by the third-party administrator with some concerns around a physician that was providing opioids, and at maybe a higher level than what was standard. Now, obviously, there can be reasons for that in many instances, but we felt it was our obligation to at least investigate this. And so we actually reached out to the health system, to the CEO, first and foremost, felt that this was their responsibility to kind of, delegate how this was going to be handled. And I was really impressed with how seriously they took quality and outcomes, and even the potential for something going sideways in this situation. Now, ultimately, we discovered that there really wasn't anything going wrong. This was just, dealing with a couple of members that really were kind of dealing with, multiple issues. But at the end of the day, we were really impressed with how the health system held themselves to such a high standard, where it was one more reminder continually of how the healthcare side of the equation holds themselves to a much higher standard than the health financing side of it does.
Thanks, Doug. Doug Geinzer, same question to you. Quality, where does that fit? And how do advisors sort of balance those two concerns?
Yeah, so going back to the whole autonomy thing, those surgeons that want to practice to their highest level like to go to surgery centers just because they're able to control that. Let's kind of stick on the opioid conversation. In the hospitals, they're highly impacted by the HCAP scores, which is the patient satisfaction scores. And if the surgeons aren't, I hate to say, doling out opioids, they start pinging and giving bad reviews to the hospital. So there's a lot of movement going on with opioid-free surgery. And I think you're going to see that cause and affect a major shift of cases being moved from a hospital to a surgery center, because the surgery centers have already been doing it for years. Like most of the surgeons that I've been working with have not put opioids into a patient for several years. They're starting to use more nerve blocks and things that will assist the patient with their pain measures pre-operative as well as post-operative. But that's really where we look at the quality measures. And the guys that are taking cases to the surgery center, they're stepping up and taking a little bit of financial responsibility for the outcomes as well. So if there is by chance some type of bad outcome or something needs to be fixed, they're on the hook for it for the first 30 days. So they're incentivized to make sure that the patient comes out with a positive outcome, as where in other environments, frankly, the incentives are misaligned, where if something goes south, it's another billing opportunity for the surgeon in the hospital and the facility to take another swing and get paid a second time for their mistakes, which that usually doesn't happen when you have a warranty out there.
Great point. So, and that goes to aligning incentives, right? Within the surgery contract, the bundle surgery contract. Uh, so, Doug Hetherington, what has Doug H, Doug G, Doug H, Doug H, what has sort of been the evolution in terms of your experience when you first started working with hospitals with health to business, right? Not as an advisor, and today beyond what you just mentioned earlier about more receptivity, et cetera.
Yeah, and again, I think this goes back to the problem continues to get worse. It's not getting better for anybody. You go back 4 or 5 years, and most of our discussions were around what is direct contracting, and we were just trying to lay out basic processes, infrastructure, why a health system might even consider this. It's been very surprising to us and refreshing, even with COVID. And then if you're aware of kind of hospital finances, they've been significantly challenged the last year and a half, kind of post COVID. But now they're literally reaching out to us. We're getting referred, from the next one hospital to the next, because they're literally now seeking solutions on how do they work directly with their local payers. What we tend to see out there, and I think is maybe the inefficiency, and the folks that have done this would agree, is that we're all operating in a silo when we do a direct contract, right? So it's really we're building this kind of custom network, narrow, exclusive provider organization, whatever you want to call it. And it really is limited to those providers in which we have those direct contracts, or maybe we've layered in another, point solution, a green imaging, a KISS card, whatever those might be, right? All can be beneficial, but at the end of the day, it isn't anywhere near, from an access standpoint, what those kind of traditional, providers have or carriers have. So I think that's one of the areas where we find that most health systems are trying to solve for that problem. And it's where the instance of, a Coral becoming an aggregator, coming in and being able to work with lots of different surgery centers, different entities to aggregate all of these access points. Similarly, as a direct contract administrator, right, we do that same thing, so that, I can be working with Doug and his team on bundles when those are appropriate. We can be working with other vendors out there that maybe have direct contracts, but we even allow others that have their own direct contracts to, in essence, put them in our ecosystem. And we just think of it as reciprocation. Nobody's really getting paid to do direct contracting today. It's like the most free work. Brokers are used to it, so we all know we do it. But this opportunity to say, hey, I can kind of capitalize on that work. And what that does is create strength to where, through all of these direct agreements, assuming they have some level of higher value than what you see in the traditional PPO world, you're able to aggregate those agreements together and almost create the patchwork of a direct contract network, if you will. So I think that's some of the excitement we see from the provider side, is that there's a realization on their part that more and more are starting to jump into this arena. And so there is opportunity for them to reciprocate, one health system to the next down the road, so that now they can meet the needs of a more robust population.
What type of hospitals are contacting? Is it across the board? Do they tend to be more rural, or is it the larger systems? Who's interested?
We don't really hear many that aren't. Probably you get into a marketplace where there's one provider, one health system. Those are maybe a little bit more difficult conversations. You get into a market where it's very robust, very competitive, and usually, we've actually seen several markets now where there are competing direct contracts. Literally, we have health systems that are all engaged in kind of programmatic type direct contracts, and through brokers, other distribution sources, putting those out into the marketplace. Certainly, rural has a lot of interest. They've been impacted significantly by kind of the financial woes and inflation that we see. So there's motivation for them, not just to find a more efficient pathway with their payers, but to also just keep the people local, right? There's kind of this propensity for us to think, oh, I got to go to the big city in order to get my procedure, when maybe just as wholly appropriate to do it right there locally. And so direct contracting can be another motivation to get them there. But at the same time, you have, very, very large health systems that have a pretty good handle on their revenue cycle, understand some of the inefficiencies that are, kind of born out of the traditional network model, and yet still have a desire to work more personally with their community employers. So it really does run the gamut. Again, there's a handful that probably at this point haven't seen a lot of motivation or interest in it. But I think, on the whole, we would probably guess 80 to 90% of most health systems, hospitals out there are interested in some form of a direct relationship with the community employers.
I see a couple of questions that have been put up on the Q&A. Don't wait until the end to ask your question. Go ahead and click on the Q&A button. Go ahead and register your question while you're thinking about it, so that we are sure to get it. You're sure to remember it. We're sure to remember it. And we'll answer them maybe within the context of the discussion, but certainly we'll make some time at the end to get your questions answered. Doug G, sort of your experience from when you started this to today. Are physicians more receptive? Are there more ambulatory surgery centers that you're able to work with? How's the environment changed for you?
Yeah, so keep in mind, I started out as a provider guy. So I've represented some of the higher performing surgeons around the country for years. And my job with them was to get them direct contracted with as many groups as possible. And that has challenges, just because when you're bringing to a small practice, hey, here's a contract from this surgical steerage company here, or this COE organization here, these 10 TPAs, each one of those needs to go through a level of legal review. And when it pans out, they're not seeing return on investment because these groups are bringing smaller amounts of lives to the contract in the equation. And it didn't allow them to scale their business because it was problematic in how they received the referrals, just everything that was required from a standardization standpoint. Coral solved a lot of that because now they have one contract that's accessed by thousands of health plans. So from a provider, whether it's TPA 1 or TPA 100, plan 1 through plan 10,000, by the time it gets to the scheduler or the administrator of that practice, it looks like it's the same. And that's what the providers are looking for. They're looking for some level of standardization where they know they have one contract. And in our world, the provider is in control of their pricing at all times. So we operate on free market principles. And so what that does is it allows the provider to list a fair price, knowing that they're going to get paid quickly. I think Doug really hit the nail on the head early on, saying, some of these carriers are dragging these providers out 3, 6, and 9 months. That creates instability in a practice because they're all like us. They're small business practices that need cash flow. And if they don't have that, it creates problems. So where some of these direct contracts were coming in, they'd ask the providers to compromise on their price, and then they delay them out on payment. And it created initially a bad taste in the mouth of the providers because they're like, I spent all this money to have this contract negotiated. We get to terms, you send me patients, and then you drag me out. That's not cool. So now what Coral's done is we've standardized that end-to-end process where the provider knows that they could set their rates. They know that they're going to make a profit. They're not looking to gouge any of the employers, but more importantly, it's predictability. They know that they're going to get paid in 14 days. They know that they're going to get paid 100% of the price that they provide. So it allows them to feel more comfortable. One thing providers will tell you, they all have issues with the carriers. They're always at some level of conflict and odds with the carriers, because keep in mind, the carriers come in every single year and they're pushing down on their reimbursement rates. When your audience that's on the call today, their employers, their premiums are going up, and everybody goes, where the hell did MLR go? Because how are we charging the employers more but paying our providers less? And in a direct contracting world, a real amount gets passed over to the provider. And in the ambulatory surgery setting, many times we're able to pay the providers higher professional fee, which incentivizes and motivates them to bring more cases into the ambulatory surgery setting. So it's a win-win across the boards. The three parties that really matter, the plan that's writing the check is writing a smaller check. The patient that's receiving care can now afford care, because many times these guys have been limping along with a bad knee because they don't have $7,000 in the bank to cover their member financial responsibility. And then the third party to the equation, the provider, is getting paid a fair amount. They're getting paid quickly. So the three parties that matter in the transaction all win from this scenario.
Well, when you align incentives, everybody wins. So that's one of the great byproducts of this direct contracting approach. Doug H., talk to us about pricing. How is the pricing, the contractual rates negotiated, and without you giving up any secret sauce here? But in terms of pricing compared to the standard model of the carrier taking a discount off of an unrealistic and arbitrary charge master price, how are you negotiating? Where are you starting? Is it a reference that you're working with, et cetera?
Yeah, that's a good question, and one that I think we as brokers typically, right, we always think in this sense of, well, what does this look like on a spreadsheet? How am I going to get my client to purchase this? And so and I think the other thing that I hear often within the broker community is, well, what's your percentage of Medicare? And I just think people have to understand, when we're dealing with ASCs, that is a completely different discussion than if we're dealing with a hospital. Yes, they may both do a similar procedure, but we have to admit the hospital has to do thousands of other procedures as well. So they're just not similar. I think what you pointed out there is that in the traditional marketplace today, there's just incredible volatility from one market to the next, one health system to the next, and even at the procedural level, there is no consistency. A fair market value does not exist. And it's why we've ended up in this discount off game. So when we sit down with health systems, hospitals, we really start with, where are the inequities being driven from? And if you just kind of get back to kind of what does this experience look like, it's usually when we have a catastrophic claim. It could be a massive cancer, that especially one that goes on over multiple years, preemie babies, twins, triplets, right? Where all of a sudden we're seeing $1 million bill charges. And that's when all of a sudden we kind of hit the freak out mode. Instability is created. And what we do is we try to explain that process of what a reinsurer goes through, what an advisor goes through, and ultimately how does that translate to the purchasing process of the employer. And what they realize is it's when that one claim hits is when we exhibit bad behaviors. Many of you have heard me refer to the term spreadsheeting, right? Page one, pick which carrier sucks the least, and page two, how much further do we have to push it out on our plan member to actually, keep this thing alive going into the next year? And when a health system executive begins to understand that, they're appalled at the behavior. And yet we're looking at them and saying, but it started with this one claim. So when we sit down and have these conversations with healthcare executives, it's, how do we do this differently? Not just how do we make it less expensive, but how to recreate stability for the employer, the advisor, the reinsurer. Because if we can do that, then we don't go through these, every 4 or 5 years where we're going to get a 20, 40, 50% increase. And instead, we stay focused on, what are we doing from a risk management standpoint? Are we bringing in solutions like Coral to make sure that our employees do have not only a good cost and easy access, but now knowing that they have very high quality as well? It allows, I think, the stakeholders in this to stay focused on doing the work that they were designed to do, as opposed to throwing the baby out with the bathwater every several years.
So how does Doug H., how does and I know it varies from market to market, facility to facility, but what sort of, I hate to say savings, but how do your contracts compare to the rates that an employer is going to see if they're in a traditional carrier PPO?
Yeah, great. That's a good question. And we say that it's market to market could be a little bit different. Some are more aggressive, and there can be a variety of reasons for that. It's not just the price. There can be some other driving indicators. But I would say we've never had an employer that has lost, meaning on a kind of a unit cost basis, were they paying more the second year? And the answer was no. It's really how much do they save? And that can be dictated by, how much steerage did we have towards the direct contracts? Did we have any catastrophic losses that year? Did they even go through a direct contract or end up at some other center? And so all those things can weigh in on it. But we've seen anywhere from probably a 5 to 10% at the low end, upwards of probably cutting costs in half. And so I think the reality is any employer that has engaged in this has realized an immediate savings. It's just how large is that? I think the bigger thing that we see, and we monitor this and notice it through our retention rates, which are 95% plus every year, there's just not the anxiety that there was before, right? Things happen throughout the year. The employers react to that. We solve those problems as they come up. But when it comes to the renewal, it's just kind of viewed as somewhat of a formality at this point. So it's this kind of constant motivation to stay after it, because I've literally had CFOs, CEOs, HR directors, even employees say it, we will never go back to the way we did it before. This is so much better. We can, kind of count on this year in and year out. We're 100% committed to making this work, which is when you're aligned with your clients to that level and you have challenges that come up, man, when they're that motivated, it makes all the difference in the world in getting to a better outcome.
So let me go ahead, Doug G, let me ask you that same question. And you and I've had some really in-depth conversations about the economics for the surgeon, for instance, especially for the surgeon, but also for the center as well. How does pricing work? What sort of, if you can give us some maybe comparable hospital versus ASC bundled surgery prices?
Sure. So in the ASC world, it works a little bit different. A lot of people always ask, well, what is that a percent of Medicare? And you're not comparing apples to apples. So percent of Medicare in a hospital greatly varies from a percent of Medicare in a surgery center. So most of the work that we do in the surgery centers is done in a bundle. And if you were to compare that bundle to a hospital Medicare rate, I've seen total joint programs that are 99%, so less than Medicare, because of how that is measured. As a whole, in terms of cost savings, most plans will recognize about a 40 to 60% cost containment or savings in things that they steer to the surgery center. And that's probably the biggest point, is how do you get them over to a surgery center? And that all comes down to proper navigation and getting them there. But in terms of pricing, again, you're going to find the surgery center is going to be somewhere between 100 to 130% of Medicare. If you're comparing it to a hospital, probably towards the lower end. Now, we are starting to do more and more percent of Medicare deals with hospitals, as well as it really presents itself in the oncology cancer space, because most of that is drug related. And they really don't have a way to bundle that. So we are seeing more direct contracts on our platform that do have a percent of Medicare. So it is a growing area, but we believe that the biggest cost containment comes in redirecting cases out of the hospital that shouldn't be there in the first place, moving them to a surgery center, and really tackling that facility fee. That's the egregious part of the bill.
Speak just for a second to the opportunity for the surgeon who is in the hospital, has probably one case a day he's going to get done, and the compensation. I think it's really attractive to know that this is what goes on for the doctors.
Yeah, so I'll use a group that everybody on the call is familiar with. So the Surgery Center of Oklahoma, Dr. Keith Smith. Keith tends to pay his surgeons usually 2 times pro fees because he wants them to break scrub to take his phone calls. And what does that mean? When a surgeon takes a case to Keith's Surgery Center, it is so well oiled and operating well that a surgeon's able to get in and out of there in 45 minutes, an hour on specific cases and get back to the rest of their day. As we're in a hospital, many times because of the mismanagement of their ORs, they may find themselves hanging out in the physician's lounge half the morning to do that one case. What ultimately ends up happening is we double and triple stack cases for that surgeon on a Friday morning. And that surgeon will go in, go bang on a bunch of cases on a Friday morning, get 4 cases done, which is more than what they get the rest of the week in the hospital. So for the surgeon, it's advantageous. They like it. So if you think of a hospital environment, a surgeon is only getting their professional fee. And so let's use joint replacement as an example, or you could replace it with spine, whatever you want to replace it with. These systems have suppressed and pushed down that professional fee reimbursement year over year over year. It's caused very bad misaligned incentives where a lot of these surgeons then go out and they start opening up what we call POD, physician-owned distributorships, where they own the implants that they're putting in, and they find themselves making more money from the implants than they do the professional fees. And then all of a sudden they're putting stuff in people that they shouldn't be putting in people because they're making more money that way. It just doesn't make sense. So a lot of the surgeons are now owning their ambulatory surgery centers because it gives them the autonomy, but they can also participate in the facility fee. So just by moving a case from a hospital to a surgery center, they can now participate in both of those and find themselves making 2 to 3 times the amount of money that they would make in a hospital, well, working just Monday to Friday, 5, 6 a.m. till 3, 4 in the afternoon, and not being on call at night. So it's a much better thing, less physician burnout, a term that we hear all too often, and they enjoy it that much, and it pays them the money that they need to make.
That's great. Thank you. So we know that the beauty of a bundled priced surgery arrangement is transparency of cost. We know what it is. It's generally a lot less, and it's known ahead of time. Doug H., how do your contracts handle transparency, particularly around cost?
Yeah. It was interesting when we first started this, it was usually just handing over the rate schedule to the employer so that they could actually see it, or the advisor, right? So that you could see it with that level of transparency. We still do that pretty often, but because of the transparency laws, we're now actually required to produce the machine readable files, just like a traditional network solution would be. For any of you that are participating in direct contracting, just know that is a requirement. So even if it's just an employer that has established a contract with a provider, you're required to provide that information. So that's just to be aware of out there. So we then in turn produce that to all of the vendors that are necessary. Usually the TPA is going to have a copy of that. Sometimes there's a third party and vendor in the background that's aggregating that information on behalf of the plan. We'll send that to them to make sure that information is produced. We also have a directory set up. And one of the things that you'll find interesting when you have a direct contract relationship, especially with a health system where it's community-based, it's local, right? Maybe it's a mile or 2 down the road from the employer. We actually do want them to have a relationship so that when, John Doe walks into the HR's office and says, hey, myself or one of my, family members on the plan, we're dealing with this issue. I need to get scheduled for a procedure, or, I just need to get into a doctor. We don't even find people calling the TPA any longer. HR director picks up the phone, and in most of our direct contracts, they have a dedicated support person at the provider that they can now reach out to, that really kind of produces similar to what kind of a Coral does, but this white glove experience, but at a community level, right? On something that's maybe a little bit more narrow. And obviously, as you can imagine, what comes along with that then is an estimate of what the pricing will be. We make sure that we furnish the benefit summaries for those larger provider systems so that they're armed with that information. They're not having to reach out to the TPA. So we really think in this direct contracting world, you're going to replicate what already exists in most of the PPO world, and then just enhance that in a variety of different areas, both from a transparency standpoint, but also an experiential standpoint for the provider and the member. And as you can imagine, if you're the HR director and right, you've got this employee in distress, they walk in the room, with one simple phone call, you're able to kind of transfer that responsibility to over somebody else. But most HR directors don't have that ability today, right? So we've actually given them some tools and empowered them where really that has been lacking in the past.
I love that. We have a question that came in. Do your programs operate in all states? So Doug Geinzer.
So we're in 49 states right now. We have about 10,000, probably 11,000 sites of care, about 3.5 million bundles that are already pre-negotiated, fully executable. Some markets are more developed than others, but yeah, we're in 49 states, and hopefully we'll get somebody in Hawaii pretty soon, so we could say we're in all states.
There you go.
Well, and you get to go to Hawaii to set the whole deal up. Yeah. Doug H.
We are not today. Now, through some of our strategic relationships with, Prime Health Services, their practitioner-only network, for example, they would be in all 50 states. That's a full integration with us that employers can purchase into. With that being said, we have just brought on a contract with an entity that is in 43 states. They operate 486 ASCs across the country. And not to be confused with what Coral is doing. Ours is in a fee-for-service model, not in a bundle. So it could still come with a few of the, kind of the hassles you get in more of that traditional side, but maybe more easily accessible for a bulk of employers as well. So we continue to see that our footprint is expanding. I'd say we're probably, with those contracts, we're in 45 plus states. As far as what I refer to as our programs, which is, I view it as a full network replacement, right? If the employer is interested in doing that, you could probably say that we participate in 8 states today.
Great, thank you. So here's a question for both of you, and I'll let Doug Geinzer start, just to be fair, since Doug H just finished. How does a broker or advisor work with either of you? Can we lease your existing contracts for our employer clients, or can we ask you to try to get direct contracts in specific markets?
So with Coral, it all starts with the benefit advisor. They are the trusted advisor to the health plan. We provide SPD language that allows them to install an amendment that creates this out-of-network benefit, allowing them to navigate members out of the PPO network. That's kind of where it all starts. The key word there is navigation. Coral is not just something that you write into a plan and it works mysteriously and it happens. It all starts with navigating. So a lot of people will ask me every single day, who are the best TPAs that work with Coral? And I respond, that's the wrong question. TPAs are there to pay a claim. The real question is, who are the best navigators that work with Coral? And we've got a subset of our preferred navigators that are navigating a couple $1 million of care every single month. We will work with those. We can work with any navigation firm that's out there. We provide some back-end support. We do charge a little bit for that. In terms of going into specific markets, if there are covered lives in a market and we do not have offerings in that market, we have a full provider contracting team that will go in there and build those out. Coral only makes money when we're saving plans money. So it's in our best interest to make sure that when you're looking for some level of service in any market that we have that there, because if we don't, we're not generating profit for our organization. So hopefully that answered your question there, Nelson.
Okay. Doug H, how do brokers and advisors work?
Yeah, I'd say the first part
HTB.
is, Doug said that very well, right? It does start with the advisor. We find our most successful clients are those that have, I don't think of them as brokers or agents. I mean, these are true consultants and leaders and pioneers within the industry. So for those that work with us, thank you. You're worth your weight in gold. Not only to us, but to your clients as well. And we're similar, that this isn't just a set it, forget it type process. We do have our own contracts across the country that we've established, but as I said earlier, we also administer contracts on behalf of others. And we're happy to reciprocate with other entities that may have direct contracts. We really believe that our clients and the populations we represent are those that exist where we are managing those agreements. So for the most part, we only charge any type of a fee on those members that we say are in our service area. We do have some percentage of savings type models, should somebody want to work outside of that. And then the other side of it is, because we are geographically limited, right? We're somewhat limited by those providers and their geographic footprint. We may not be a great fit for every population, every employer, or every advisor. So if you're in those states where we operate, obviously we would love to have a conversation. We become relatively turnkey, even to the degree that we are now integrated with several small group level funded carriers. and have groups as small as 2 participating on our direct agreements at this point. So I always say that, you know, a direct contract is just that, it's a contract. It's, can you programatize it? Can you productize it? Or can you even marketize it? And that's what our goal is to bring a direct contracting solution around a given community health plan, the ability to actually marketize this so that as an advisor, you come to H2B in, you know, Cincinnati or Boise, Idaho, wherever that may be, and we're literally able to bring you multiple solutions that could all potentially fit the unique needs of your client.
So if there is an advisor out there with what he or she believes may be a good candidate for a direct contract, is that a conversation you'll entertain? Doug H?
We'll take that.
Yeah, absolutely. You know, we that's actually how we are getting ready to open up in Oregon right now. We're finalizing an agreement with a legacy health system up in the Portland area. We're very robust in that market, and that was literally an employer and an advisor that got it, hired us to come in and basically begin the process. And we're at about that 12, 16-month mark right in there, and we're kind of finalizing this. And you know, this is a large employer, a couple thousand employees, that is probably going to be realizing $1 million plus in savings. So they've even looked at it and realized this initial investment to have us do this was a drop in the bucket compared to the long-term savings. So we'd absolutely entertain that. And what's interesting is versus, you know, I think repricers often have said, hey, we'll go out and direct contract on your behalf. It's interesting when they're out there saying the hospitals are the problem, and then they go in and say, but we'll go set up a direct contract with them. Call me a skeptic, but if I'm the hospital, I'm not real thrilled about this relationship. We've kind of started off on a bad foot, versus when we call in and say, yeah, we represent employer ABC. They hired us to come get a direct contract with you so that you all can have a better relationship. That's a different conversation, and really does, you know, allow us to come to fruition to some terms of agreement much quicker and much more effectively, in our opinion.
You know, Doug, I think hospitals, well, let me start over. We can disintermediate the insurance companies, and we must when we can. We can't disintermediate the hospitals, nor should we want to. And I think the hospital's been unfairly demonized by certain voices in our industry. They are culpable, but they've been allowed to abuse the system by the carriers. So I think, you know, building relationships with the hospitals is the most sensible thing we can do. And with the providers more broadly, taking in the ASCs and the physicians that Doug works with, Doug Gainsworth works with. I did get a question here that said the pricing question was not quite answered. And Doug H., I think that was referring to you. So how do you negotiate with those hospitals? Well, in other words, we know how the carriers do it. How are you doing it differently?
Yeah, so great. That is a good question. So first and foremost, there is savings to be had, but it's where are you going for it? Are you just going to go out on across the board and I want to be 5% less than your lowest BUCA? That's certainly a way to approach it. If we can have a hospital start with a discussion around a Medicare, a multiplier of Medicare, that is preferable. That seems to be the vocabulary that our industry understands. But at its core, we really do believe that instability is the problem. And so our negotiation does start with education. It then goes to where are those largest, in particular for inpatient DRGs, that are going to happen, that are going to result in that level of instability. From there, we actually score the contracts, bring it back to them, and then we take it to the reinsurers in the market. And I would say on the whole, if you're looking at it in aggregate, we're somewhere between 10 to 20% less. We have others that are higher, but 10 to 20% less in aggregate than what you would see in the traditional carrier model. But we also know that there's a lot of savings to be had in other areas as well. And so that's why we often realize our plans are saving, you know, much more than just what we're producing for them. It's just the fact that they've broken away from that kind of network infrastructure that now allows them to, you know, exhibit those abilities to, you know, contain costs and do a better job within their population. I have contracts that literally I would say I'm on par with the best carrier, but just we've made some very, I'll say structural changes in the agreement. And then on the other end, I would say we have some where we're 15, 20% right out of the gates, out of the market. That's just, we kind of know where we're at. We do prefer a Medicare multiple. We try to stay away from a discount off of bill charges. That seems like a kind of a deflating mission anymore. And the last part of it is we try to meet the health system where they're at. They're not all the same. They don't all price the same. Everybody's a little different. So we typically find out what they're good at today, and then we inject in our experience from across the country to demonstrate where we think we're better. Probably one of the best examples I could share is a preemie baby. We actually had this out here in Idaho, where in that situation, if you were with a traditional network, that claim would have been paid out at about $575,000. Under our arrangement, it was paid out at about $140,000. So you can imagine that changes the equation when you get to renewal and you're looking at your loss ratios. And what I will tell you is very fair renewals come out of the reinsurers when a direct contract is in place in most instances.
Yeah, I think we did a whole session yesterday on stop loss and underwriting the stop loss, and you're absolutely right on a direct contract, getting a nice decrement from the underwriters. Let's do our last few minutes, a couple of quick responses, a couple of quick questions, quick responses from some of the folks in the room. Doug Geinzer, how do you address the anesthesiologists?
It's built into the bundle. So some of the surgery centers are owned by anesthesiologists, so it's kept really, really simple there. Others that need to bring in anesthesiology as a third party, they're either doing a per unit fee that is known. Many times we'll provide just a CPT list and say, give us an exact amount on each one of these CPT codes. I also have one group that comes in there and he breaks it down into, it's either a small case, a medium case, or a large case. Those guys are just turning the gas on and off and they're getting in and out of the OR. It's one of those three cases and we'll pay them accordingly, one set number.
Fair enough. Thank you. Doug H., how long does it take to negotiate a direct contract?
Anywhere from a few days up to a few years. We've seen a little bit of everything. And I think the first part is what's the motivation for that provider to do it? You get guys that are, kind of a DPC type mindset and they're ready to go today, right? They just want to review the terms, the reimbursement, and they'll sign. You get into a larger health system that's maybe even regional, may have, a variety of executives within that health system that are part of the exploration and decision process. Kind of how much education and understanding they have today can certainly speed it up. But it is not something that we should look at and say, hey, it's October 1, we're going to have this done for the January 1 renewal. When we communicate with hospitals, we're trying to get them to wrap up any contracting efforts in kind of Q2, very beginning of Q3. Otherwise, we already know we're dead in the water going into January 1.
Okay. Doug H., do you currently offer services in Texas?
We do through a large contract we have with USPI, which is just finalizing right now, a variety of ASCs and then access through our practitioner-only network partner. But we do not have any health system contracts. I would not consider that to be a state where we have programs. With that being said, I am familiar with a handful of vendors that do and would be happy to promote them as well. So.
And can you consult with somebody in Texas who maybe has a hospital?
Very possibly. I know I've been invited down there by a few folks to go sit down and have some of these conversations with the local health systems. Some markets are more receptive than others. You get into the DFW area and, direct contracting, both on the bundled side and on fee for service, has been going on for, decade plus. So that's a great market. I think it's like Wichita Falls and some of those others I've heard of are maybe a little bit more challenging. But, the reality is we do believe it'll permeate every market at some point in time.
I agree. Gentlemen, Doug H., Doug Geinzer, Doug Hetherington, thank you so much. This has been fantastic. I think everyone in the room now understands the value that you two bring to the process. You are absolute rock stars. And I really appreciate you being here in the Healthcare Lounge. For those of you in the room who might be interested in some more information on direct contracts, and Kendall will put this in the chat right now, the connection, the link to the Think 360 conference in Washington, D.C., which is the Healthcare Innovation Congress. Doug Geinzer is going to be part of a panel along with the remarkable Kristen Dickerson, Dr. Kristen Dickerson, who is the founder and CEO of Green Imaging, which is another direct contracting play in diagnostic imaging, along with advisor Mike Patton, I would say supervisor Mike Patton with Palomar Consulting. And they're going to be talking on the topic of repricing healthcare, RBP and direct contracts. As the chair of the benefit advisor leadership track at Think 360, I hope you will consider joining us. It is July 20th to 22nd in Washington, D.C., and we have an entire agenda designed out for brokers and advisors that I think you will not want to miss. Doug Geinzer, Doug Heatherton, thank you so much. Great to see you guys and look forward to seeing you all soon. For the Healthcare Lounge, I'm Nelson Griswold. See you next month.
Thanks, Nelson.